Welcome to Medical Experts in Football. I'm Taiwa Deshikbin, your host.
One of my missions as the director for the medical committee is to make sure their needs and their wishes and their voices are heard the most, because it's absolutely athlete centric. It has to be. And maybe some of that bias comes from me looking at Tony going through an ACL, a meniscus, an Achilles, two groin repairs.
That's Dr. Holly Silvers-Granelli, a PT and researcher. She's also the owner of Velocity Physical Therapy. She's held many roles within FIFA, many of the professional sporting leagues. But today we're going to chat about her work in the MLS. She's the chair of the Major League Soccer's Medical Assessment Research Committee. We talk about her New Jersey upbringing, PhD differences in the States versus Europe, the impact of centralized medical electronic reporting in the MLS, and of course ended off with tendon rehabilitation considerations for clinicians as well as athletes. So sit back and enjoy. I was reading that you were actually from Kearney, New Jersey. Is that right?
Yes, I'm actually here right now.
Oh, is that where you're at? Okay.
Yes.
So that's known as a soccer town, according to Google. In 1870, immigrants from Scotland and Ireland came to work, and these companies pretty much got the town booming. So is soccer a huge part of your upbringing?
Oh, absolutely. So my mother's from London. My father's ancestry is from Ireland, but absolutely, we grew up in this town, and it was really a lot of us were first generation kids from immigrant parents. And in the spirit of full transparency, my brother-in-law is Tony Meola.
Oh my God, please don't say that. Funny story was I was looking up people that came from there that are like obviously men's national team. And I saw Tony and I said, oh my gosh, that name is familiar. And it's only familiar because I had reached out to him on LinkedIn a long time ago before I knew I wanted to be a sports journalist. And he had reached back out to me and genuinely gave me so much good advice that I said, oh my gosh, that's Tony. So that is
my brother-in-law. He's married to my older sister, but we all grew up in the same town together. And then also Tab Ramos and John Harkes are also from our hometown. So in the 1990 sort of 94 national team, we had three starting players, like three of the starting the 11 were from my hometown, which is sort of astounding. You think incredible. It's a small town of 30,000 people. So
yeah, because it sounds like a blue collar, town, right?
Yeah, very working class. We grew up sort of outside of Manhattan. You could see sort of the Manhattan skyline from my mother's doorstep. And so you had sort of the access to culture and museums, but it was also like a little bit of a Pleasantville in terms of like, we never had a key to our house. It was a very safe community to grow up in, but we also had obviously wonderful coaching. Like one of my youth soccer coaches was Huey O'Neill, played for Celtic. Wow. Like it just fascinating because we had no idea.
It's like, okay, no big deal.
It was just, it's sort of such a part of the culture. Like on any given weekend, the high school team would draw 3,000 to 4,000 fans for a game.
That's
it's just really, so it's really, obviously I love the sport, I love the game, I love the research, but it's really part of my DNA.
Yeah. So when did you start playing in? Did you play all the way up until high school? What position?
Yeah, I was a central midfielder. I played in youth, a little bit in high school, and then did not play in college, but I just thought I loved the sport, and I just loved the sports medicine element of it. Yeah. And it was interesting, kind of getting back to Tony, one of the reasons I went into examining the notion of ACL mitigation, he tore his ACL when he was playing for Kansas City at the time. And it was just such a fluke thing. It was on a goal kick. It was just such a random mechanism. And at the time I was just finishing physical therapy school, and I wound up meeting up with his surgeon, who was Dr. Bert Mandelbaum, who was the team physician for the national team and still is involved with the national team. And just like, we could do better here. There should be some areas of improvement. So the ongoing joke in my family is that, well, I'm glad my brother-in-law says, I'm glad tearing my ACL has made your career. He said, well, lemonade out of lemons.
That's funny. It sounds like I should probably get him as a guest just to talk about his
absolutely. He's in your
experience.
world. Yeah, he's
That's
he's a
funny.
broadcaster. So
Yep.
yeah, he'd be a good guest. I'll put in a good word for you.
Yes, you should. Please, please, please. Well, in case anyone ever goes to New Jersey, because I'll be honest with you, I have never been to New Jersey, and I just imagine it being so busy and just, I don't know. I just want to be able to relax. Are there places in New Jersey that you would highly recommend someone to visit if they're on vacation or if they have some downtime on like a business trip? Where would that be?
Oh, absolutely. So of course I'm biased because I was born and raised here, but I think unfortunately people's sort of stereotypical observation of New Jersey is not often held in the highest regard, because you fly into Newark Airport, the ports are there, it's not exactly particularly sightly. However, if you get to the north, to the west, it's absolutely gorgeous. And then this time of year, I mean, the beaches are phenomenal. So we're heading there later today. But the Jersey Shore, my father-in-law lives near Bradley Beach. So we will head there and visit him. But it's absolutely beautiful. It happens to be a beautiful day today, and it should be. But it's really a really, really wonderful place. I mean, the coastline extends for hundreds of miles, and also Long Beach Island is really pretty too. And there's a lot of state parks. It's really a pretty place, particularly in the fall.
Okay. So, yeah. Now, I was born in Brooklyn, New York, but I don't consider myself a New Yorker because I've only lived there for 2 years.
Okay.
But New Jersey folks, are they just like New Yorkers? Just got to get it done, get out my way. Sure. What's their personality like?
There's a bit of an intensity. I remember when I moved to California for graduate school many, many years ago. I remember feeling, wow, things are really slow here. I think because I grew up in northern New Jersey, so it's very kind of similar in terms of pace to Manhattan. But if the further south you go, the further west you go, it's much more balanced, if you will.
Okay. So that's where I need to go.
Yeah, absolutely. And I just think, it's funny how obviously it's not a very large state, but there's really different personalities based on where you are geographically in the state. Yeah, it's interesting.
Good to know.
A lot of good food.
A lot of
really
good food.
Loyal people and very loyal
to what sports teams? I'm trying to think. New Jersey.
I think
New Jersey
of the wonderful
Jets
things, so there's we have two of everything. So there's Yankees, Mets, Jets and Giants. You have Devils, Rangers. You have obviously NYCFC and Red Bull.
Right.
And you have Devils. Did we say Devils, Rangers? There's really two of everything.
That's impressive.
So you can,
So you're loyal to all these teams, despite you being involved with all the other clubs around the world.
Well, I can't have any allegiance in MLS, but,
right.
But I'm an equal opportunity supporter of the league. But I would say we're Giants and Yankees fans and Devils. Sort of interesting, but
well, I know you're on vacation now, but you got 2 kids, you're married, you do all this stuff, which we'll get into. What's like a nice little family thing you guys like to do when you have free time, if you ever have free time, which I can imagine?
We carve it out. We're very lucky to live in Santa Monica, California, so we take full advantage. We're very outdoorsy. And the climate allows you to be outdoors all year round. We're really lucky. So beach day, we love to run. The kids will still sort of, with some bribery, sit in the jog stroller so we can get them to go.
How old are they? Are they young?
5 and 3. My son will soon be 6. So it's fun. And they love to be outdoors, and we just fully exploit that component of living in Southern California.
I wish I would have been paying more attention, but when I was out in California with Fox Sports, I had to go to the studio. I think it's in Culver City, but it's right near Santa Monica.
Yeah, it's very close.
Why didn't I think I could have stopped by Holly's clinic? But I'm sure I'll be in California
next time
for some other reason. But how did you find your way all the way out to the West Coast?
Grad school. So I did my graduate work there, and then teamed up with Burt Mandelbaum. So I was their director of research for about 15 years at Santa Monica Orthopedic, which has since merged with Curlin and Job. So they're more sort of the well-known name, if you will. And then I left to do my PhD at the University of Delaware with Lynn Snyder-Mackler and Amy Arundel, who you know,
Yeah.
my cohort, really great,
Great.
wonderful group. We were so lucky.
You guys are great.
I mean, had a wonderful, just the whole lab was phenomenal. And Lynn, Dr. Snyder-Mackler is phenomenal. So just a really great opportunity. And I did that after 15 years of being a clinician. So I was sort of the old gal in the lab, a little bit of the matriarch, but there was something really wonderful about going back. Really, I felt during the master's work where I was sort of looking forward to the end just to kind of embark on my career. And this was just a very different sentiment of going into a PhD program after working for so many years and having lots of good ideas and hypotheses that we wanted to test out, and really savoring the experience without taking the risk of sounding too cliche. But it was really a wonderful education is wasted on the youth in so many ways, because I felt like, you're sort of looking forward to the end. And this, obviously I was looking forward to the completion, but I really enjoyed the process.
Yeah. And I'm excited for us to get to that too pretty soon. But you mentioned how Tony, when he had his ACL injury, that kind of opened your eyes. What more could we do with ACL? But becoming a physical therapist specifically, how did that even pop in your head? Because I think you majored in like biological science, specifically molecular genetics. And to me, that sounds more like real medicine. Was physical therapist in the picture?
Yes, well, I was pre-med at Rutgers, and I really love genetics. I still love genetics. I think it's really fascinating to me. So I was a little bit of a molecular genetics geek. That was sort of my bias or focus. And then I had an injury during college, and I had a really great physical therapist who then I went on to work for, Dean Pinciotti, and he was part of Professional Sports Care, which I think has gone through a name change at this point, but this is back in the 90s. And I just thought, I had interned at hospitals as well, just kind of trying to figure out which branch of medicine I'd like to go into. And I found what I loved about physical therapy is the ability to institute change and really make meaningful change on people's like day-to-day lives, but also the relationships, like, because we had so much time to spend. And that is to this day something I savor now. In my clinic, we're a little bit lucky because the model is like 1-to-1 for an hour. And the things I learn and just these like my patient population is so interesting, and the conversations, it's really a wonderful career.
Yeah. I agree. Sometimes people are like, do you not get tired of talking? And I'm just like, gosh, I'd like to think that I should, but I guess I've really found my passion because I love being a physical therapist too.
Good.
Huh.
Yes.
Well,
and I think like every hour is a new chapter, right? Every hour it's a different diagnosis, but also a different person with interesting experiences.
Yes.
So it's fascinating.
And they teach you things that sometimes you would never even know outside of PT, and you're like, oh, good to know.
Absolutely. Like, we're so lucky because we have exposure to people who do lots of different things for a living. Unlike, like, my husband works in finance, so his day is a little bit more myopic in the sense that he talks to similar types of people all day. And for us, I might have a producer, a professional athlete, a high school athlete, a chef. Like, it's just fascinating.
Cook me some food, chef.
Exactly.
Well, you practice in a outpatient private setting for, you said, probably at least 11 years before you decided to pursue that PhD at the University of Delaware. What were some of your early experiences in that clinical setting, maybe that pushed you to go on to pursue that PhD? Did you feel something that made you realize, okay, there's something more that I really want to tackle at that point?
It's a really good question. And so at the time when I finished my graduate work for physical therapy, it was at the master's level. So I had an MPT clinical degree. And oddly, I 1 year, not even like 6 months after graduating, I started working for a nonprofit research foundation. And we started doing research right away. And I was very quickly and keenly aware of the fact that there was a little bit of degree bias, if you will. Like, for example, if I would go, a couple of years in when we had some data to present, if I was presenting at a meeting, there were a couple interesting situations I was in where I was asked by an orthopedic surgeon, like, oh, you only have a master's? That was interesting. And then one going to pick up my speaker credential, like, oh, what position are you picking this up for? Like, and it was just like, it was sort of interesting.
Yeah.
And I understand it. There's a lot of rigor and nuance and wonderful things that come out of doing MD, PhD, or, you know, whatever advanced degree you're looking on getting. And I think for the level of research we were doing and the level of research we were, the journals we were publishing in, and my own interest in, like I said earlier, like, I've got these ideas, let's see how this feathers out in the biomechanics lab. Those were all my sort of, there was like a sort of this Venn diagram of variables that came into it. And just, but the main one being, I'm just like a pretty a type A personality and pretty driven. So
very driven.
Thank you.
Beyond driven.
Probably to my husband's chagrin at times, but I just think I didn't want to look back. And I had a really candid conversation with Dr. Snyder-MacLeod at Isokinetic one year, and she's like, you need to be doing this. Like, you're doing the research already. You're doing all the work. You may as well get the credit you deserve at the degree level that this commands. And I'm like, you know what, you're absolutely right. Yeah. So I did it.
Okay. So when you decided to do that, what was the transition like from working in the clinic versus strictly doing the research? Were you even working in the clinic at all?
The university was really wonderful. So I sort of was doing the COVID hybrid academic experience before COVID. So this was like, so they allowed me, I was going to 2 weeks a month and then just logging on. I was live for every class because the curriculum is such that it was 2 years of didactic work and then 2 years of, you know, data collection / you know, analysis. The interesting thing with having been a clinician for so long, I came in sort of armed with ideas. So we were able to start the data collection really early on in the process. It took 4 years, but that was pretty cool because I was able to start data collecting after, you know, year one, which is a little bit unusual. And Amy and I did, and Ryan Zarzicki, I mean, just so many wonderful people in that lab. We did a lot of collaborative work together. And it was fun. Like I said, I loved going back, like taking a bunch of statistics classes, things like, I was using readily like writing, but always deferring to the biostatistician, but now having like a more expanded knowledge base of that. And like, oh, this is why we're doing this. And this is really a good statistical tool to use when we're looking at X data. And obviously that program is so respected, you know, for obvious reasons. I mean, it was interesting because it was different. And I think now since COVID, I think people are really, it was more of a European model PhD, if you will. But there was a little bit of reticence on some of the professors' behalf, which was completely warranted. Just like, well, we need you here. Are you going to TA? I was like, yeah, I will be here 2 weeks out of the month, like at your disposal. And I'll be live for every class, interactive like this. But this is before we really had Zoom and, you know, and so it was interesting. It was a little bit of a learning curve, I think, for everyone. And I didn't want to give a sense like I was trying to exploit a situation, if you know what I mean. I wanted to be super, I wanted to be deferential to the curriculum, to the system, and making sure nobody felt like I was doing less because I was doing slight things remotely. So it was a little bit of a dance, but I can assure you, I took every exam. There was no slack cut.
Yeah. Now you said it was, I guess at the time, it was more like European style. What do you mean by that compared to the States?
That's a good question, because if you look at people who do their PhDs in Europe, it's more, there's really no didactic curriculum associated. There's just sort of this evolution of learning and reading and studying under a mentor or two based on the institution, like if they pick a project. Where in the US we still have that very traditional model of like, you know, I had about, I have to go back and look at my transcript, but about 56 to 60 units of actual classwork. So you know, in advanced physiology, many statistics classes, biomechanics, of course, several courses. In Europe and elsewhere in the world, that's just not necessarily the case. They don't typically do structured classwork. It's
Okay.
more, yeah. So I think it's more of a professional model, if you will. Like that model probably would have suited me a little bit better. But to be fair, I learned a ton. It was really wonderful to go back in sort of the classroom environment and, doing group projects but personally, and again, I'm biased because I went through that particular system, but I do think there's a lot of upside to that, because there may be things, our own conformational biases. I wouldn't have necessarily explored that on my own, like reading, doing a
Yeah.
deep dive into a certain aspect of the curriculum where we were sort of forced to take. We took ethics classes, and it was also very multidisciplinary amongst many PhD programs at the university too. So we were taking classes with the engineering students, and so that was really great. So we had lots of collaborative efforts across programs. And different PhD tracks. Even some of the master students were in some of our classes, which was really great. And I really thought that was a wonderful aspect to a more US based PhD curriculum. But on the flip side of that, as a professional, for people going back, I can see the real allure of a more European style PhD, because you can still maintain your career if you're going back later in life and you have children, and financially it's tough just to kind of put the brakes on. So, but having said that, I do think COVID has helped in the sense where there's now, let's entertain the notion of a more hybrid model.
Yeah.
Because it's a win-win, quite frankly, I think.
Yeah. It's funny that you say that, because after I took my orthopedic exam, I didn't know my score yet. I immediately started journalism school. And I remember I met with the advisor, and I'm just like, is there a way that I can take these classes online? This was before COVID even happened. And he's like, there's no way, Taiwo. This is a very intensive master's program. And all of a sudden COVID happens. Everything's online. Obviously, I'm not happy that COVID happened, but I'm just like, well, I can still work and do classes online because they have to figure it out. So I agree with you. It allowed me to still make some money while I was in journalism school. Well, I am curious because Amy, it sounds like she had Snyder Mackler for her preceptor. Who did you have?
Same. Yes. She was both of our advisors. So Lynn's, Dr. Snyder Mackler's lab, oh gosh, she's a rock star. There was probably 6 of us at the time. Amy and I were on the same exact track. So we started at the same time, finished at the same time. But Ryan Zarzicki, who does a lot of work like in the neural world of looking at cortical excitability after ACL injury, which I find completely fascinating, like Dustin Grooms, Meredith Chaput, all of their wonderful work. So Ryan was about 6 months behind us. And then we had Elizabeth Wiseland. I mean, just doing so much great work in the OA realm. So Celeste Dix came and started right after us. So there's probably a moving, almost this amoeba-like transition of students. And there's always about 4 to 5 to 6 that she's advising at any given time.
That's impressive. And she's still doing that too, right?
Yeah.
At least from what I've seen.
Yes.
Now, when you started your PhD, you had obviously many years of clinical experience, but I imagine there were probably some areas as a clinician or just maybe things that you might have viewed, and not saying that it was a true weakness, but maybe there were areas that you could develop. What were some of those areas early on in your studies?
Yeah, it's a great question. Like I said, I think, I think I've been working, let me do the math. I was working for 14 years before I rematriculated, if you will. And, and I'm in the sports ortho world. So we get into our own silos, don't we? So there were things like, I remember taking an advanced physiology course, and we're talking about like the PEG test and frequency of movement. And the way I interpreted a question was completely from my bias of like orthopedics, like, oh, I'm looking at how well this test can be done from a accuracy and precision perspective. And the professor's like, no, we're looking at like hertz and like cycles per second. And it's just really fascinating, because I'm like, wow, again, taking that sort of more myopic sports ortho lens and the way we look at things, and then broadening that vision. And I think that was one of the more remarkable things that came out of like, oh, hey, let's look at this more macro versus micro. And I think we all can kind of sometimes get guilty of that, in work and life, socially,
Right.
So I think that to me was a really nice reminder of, I try to do that, like even with a diagnosis, like, hey, let's look at this like larger pictures and make sure we're not missing any nuance. But I thought that was pretty fascinating. And that was one specific situation that stood out to me. And there were several like that along the way. And I think, again, just the cross hybrid nature of the program, where we had so much interaction with other disciplines, I thought that was a huge strength, because the way they look at a problem is just their prism's a little bit different. It doesn't make it wrong, doesn't make my vision wrong, but I'm like, oh wow, what a wonderful way to combine forces and attack this particular issue from many different angles and get ostensibly a better outcome.
Yeah. And like you mentioned, I think for every clinician, it's always important to still look at the bigger picture, not just specifically the actual injury itself.
Yeah.
Now, you did your PhD, and I know that you also took the exam to specialize in orthopedics. Was this in between that? When was that?
Oh yeah, I never did my OCS. That's a funny. It's sort of a.
It's always, it shows up that.
Oh yeah, no, I don't have my OCS. Many people want me to have my OCS. I think at some point I'll do it. I just never. Yeah, I don't have that specialization. And congratulations, hats off to all of you who have done it and successfully, because it's no. It's a wonderful designation, and I would love for us as a profession to do a better job of highlighting what that actually means for clinicians who have successfully done it, in the way that I feel like orthopedic surgeon residents do it. Oh, I'm a fellow of X, and I think that should be something maybe complete sidebar. We could do a little bit better as a profession, just because it's such a wonderful accomplishment. And all of you should be heavily applauded for going through the process. So
I learned a lot. And and I feel like a lot of things you learn, you still can look back and say, oh, this is why I did this. And I'm still learning. It's not like I'm a very old clinician, but it was a very, just like the PhD was a real commitment to really studying. Well, I do want to ask, because there are some people that obviously want to be involved in like Major League Soccer, different things like that. You weren't born in California. You made your way out there because of your master's, and you happened to get connected with that soccer population. Because I know that I saw that you were a director of rehab, a physical therapist for LA Galaxy. Like, how did you make a name for yourself in California? Because this is a competitive soccer state in general, right?
Yeah, difficult. You know what? It was interesting because I volunteered. What was nice about having connections with like Dr. Mandelbaum, there were absolutely some inroads made, and quite frankly, some might think my connection with my brother-in-law may have been an inroad, and in fact, it was quite the opposite. But because I honestly, I didn't want to be perceived as this is like a nepotism situation. I was really. So I have actually a funny story about that, which I'll tell you in a second.
Yeah, I would hear it.
But I started volunteering. I started volunteering with Chivas, was the first team I was associated with, and I would go down and do a free Thursday clinic after training, and then I would do Saturday game coverage, and I just absolutely loved it. Like, I think one of the wonderful things about this profession, and if anyone feels this way about their profession, like I honestly don't feel like it's work. So I just love being a part. I love being immersed in it. People were like, why did you do that for so many years? I'm like, but obviously your hard work and your work ethic, for the most part, largely pays off. So that's where I started. And then obviously we shared a stadium with the Galaxy. So then there was a lot of would you help with this patient? Or if this one's a little bit more difficult, or we're having some struggles with this particular player getting back to play. And then I took a position with the league to be one of the co-chairs of their something called MMARC, which is the Medical Assessment Research Committee. And basically we oversee the research being done by the league, and we're really expanding that. We have a really wonderful relationship with the University of Delaware from a human ethics IRB perspective, and for those individuals that are working with clubs who want to do research, we now have a really sort of organized avenue to do that. But getting back to if someone listening is really interested in getting involved, I would say I did work at the youth levels. I did work with like local clubs. Obviously, there's no shortage of that in Southern California. So many kids are playing. But I would volunteer and do sort of ACL mitigation workshops for them, or do you need help with screenings? Also did some work locally with Pepperdine University. And again, just very voluntary. I would say the first, 6 to 7 years of my involvement were unpaid. And some might say you're crazy, but I think like particularly with MLS, particularly at that time, there was not a lot of money and the budgets were tight. And I recognize that. But all of the relationships that I had with the players, at that time, Ante Razov, Jesse Marsh, Claudio Suarez. I mean, we had Bob Bradley was coaching, and Preki. You had, Jesse's now, making incredible inroads in the Premiership, and Ante's at, as an assistant at LAFC. So it's, and it becomes this sort of family, and you just grow this incredible network. And I say network because I don't want that to sound like an exploitive thing. I'm just a network of friendships, and you have these kind of like really wonderful experiences taking care of these people as players, and now they're becoming managers.
Yeah, I know.
But the one funny story I wanted to tell you, because I did not tell anybody my relationship with my brother-in-law, and Chivas was playing New York, and this is Red Bulls at the time before NYCFC was in existence, and it was a playoff game in LA, and my brother-in-law had a ridiculously spectacular game. Chivas wound up losing, and I waited till the very end of the game, and he was being interviewed probably by one of you, and everyone's back in the locker room, and I waited because I was very subtle about it, and I walked up to him and I gave him a big hug. I'm like, hey, congratulations. And the film was still rolling, and I walked back into the locker room, and the guys were like, what are you doing? Hugging the enemy. I was like, I didn't know the cameras were still live. I'm like, oh, that's my brother-in-law.
That's really funny.
So the cat was out of the bag.
Well, initially, because like you mentioned, MLS has came such a long way regarding to even just like the medical procedures that are in place. At the time for you, it was still like up and coming. When you were first like going to present these programs to these teams, what was the most challenging aspect about it? Because I imagine one, yes, you're female. Yes. Obviously in sports medicine, we don't have as many females, period. What was it like for you initially?
Yeah, I think there were certainly some challenges. But again, I think that the way I always view that is like, look at that as a positive, right? So you don't, victimize is the wrong word, but I never looked at something like, oh, hey, this is like insurmountable. Just this might take a little bit of a different workaround. And I think if that might be a good approach to take if you're thinking like, oh, I'm getting doors closed on me for X reasons. It's like, well, just the persistence, the subtle persistence can help. But I think one of the big obstacles we had, like the budgets were small, and we had very little access. It's completely different now, but like in terms of testing, no one had isokinetic testing. No one was doing EMGs. No one was doing any of this. And in fact, most of the medical teams were completely voluntary too, which is sort of changed depending on the club. But it's really wonderful now. Like we just had an MLS call earlier this week, and looking at, all the sophistication in now EMR. We didn't have a centralized EMR. Right. So like, we're trying to like look at data and like, extracting it from people's Excel sheets at the time. And now it's, just massively sophisticated, like in a dashboard system. And we can look at things like really granularly and really promptly. One of the wonderful things I think about MLS, because of the way the league is set up, and it's a single entity league, which some people may think is a shortcoming, from a research perspective, it's unbelievable because we have access to all of the player data with their consent. We have a wonderful relationship with the players union, and I think that's really important. Unlike perhaps some other sports in this country, one of my missions as the director for the medical committee is to make sure their needs and their wishes and their voices are heard the most. because it's absolutely athlete centric. It has to be. And maybe some of that bias comes from me looking at Tony going through an ACL, a meniscus, an Achilles, 2 groin repairs, because now as these players age and, retire, and our dads and, looking just to lead a normal active life and have their 2.0 version of themselves in their second career after retiring, it's very, very important that we consider that. And so I think one of the, oddly, where I was early on in my career, I didn't want people to know about that relationship. I oftentimes bring that up now because I want people to know that's where my heart is. My heart is with you. And I think that's such an important component of like what we're trying to do with MMark. And our mission is completely predicated on the wellness of the athlete during their career and absolutely extending afterwards.
That's awesome. So how much hours do you spend with doing like MMark? I'm assuming this is a weekly thing you typically meet.
Daily. There's always something, in terms of guiding people. Oh, hey, I want to do a project. They've never done an IRB before. I'm like, okay, let me help you. I want to do a project looking at data in Philly and some other teams. So we have a whole process in place where we have, they have to apply for we have this whole smart sheet system where they have to apply for basically permission to proceed internally. You have to have an external IRB, and then it goes through the players union and legal just to make sure everything is sort of copacetic and everybody's needs are being met. The one cool thing about all of this, because if you look at like the model that Jan Ekström has set up with UEFA, we can absolutely, and our goal is to sort of recreate that, but even perhaps in a better way, because we'll have year-long data across the board for an entire league. And that's unique because UEFA is more sort of, I guess it's more, from a competition perspective, it's more like tournament based. And many leagues throughout the world are not sharing data. In fact, that would be blasphemy to like share data amongst clubs because they think it's proprietary or there could be some trade secrets or things like that. And I think, again, Prism, let's flip the prism. It's like, no, this is to benefit. If we can expand that cohort, so the population is, over 35 teams versus 2 or 1 internally, we have a real opportunity from just from a power analysis perspective to really exploit that in a good way, really help more people in a shorter amount of time.
Okay. Interesting. So do you feel like your role as a rehabilitation consultation for some of the major league teams like Toronto FC, Seattle Sounders, I think LA Galaxy, helped you transfer some of those skills to this MMark position? Or do you think,
Oh, absolutely. Yeah, because I have relationships with many of the teams, and I guess some of the, I've been called by some people like the Olivia Pope of difficult cases. So sometimes I'll have someone come in like, oh, we're just having trouble. A new set of eyes, like that, how that goes, where you've been looking at something and you're like, oh, we're just not getting where we need to be. And sometimes just having another look by a new set of eyes. But I really love that component of it. So that's why I'm a little bit of the Switzerland, because I can't really have an allegiance, but I love working in that capacity. And then absolutely, because then those ideas go directly to the league. And then we say, hey, we've got a hamstring issue, or we've got, look at what happened in Atlanta this year with this like sort of random multiple Achilles tendon tear
I know,
situation.
I'm in Atlanta and I'm like, what the heck? I need you guys to be healthy.
So we literally had a call that next Monday and we're on it, working with Margot Patukian and Jeff Vegas, and we're like, okay, let's figure it out. And this is the beauty of the EMR, because we can go back. Where are they in comparison to the league? Where are they in comparison to historic data? What has changed? What variables? So that's the beauty of centralized, like electronic medical record reporting and sharing data across the league, because otherwise you're looking at this in a silo, and sometimes the facts could sort of get distorted. But when you're looking at over the league, did any sort of away players get injured there, or are they all Atlanta players? Like, did you have somebody come in, is it a field situation? Is it an environmental situation? Is it a loading issue? Like, and now we have all of that data available to us to like tease through it, in a Sherlock Holmes type of way, and really do your detective work and figure this out, because you can't wait till the end of the season. I mean, you can't risk another injury. You have to be quick. Right. So then again, this, because of the sophistication and the evolution of what we're doing internally, has been really wonderful. And we still have work to do. We're by no means at the top here, but I think I will say this, and again, biased because I'm involved, but I absolutely love the group I work with, and everyone's so committed to, and Jeff Agus, obviously being a former player, a national team player, that same thing. It's really player centric. I say that in a way that I don't think a lot of other leagues could say it in the way that MLS can, and I'm really proud of that.
That's awesome.
Yeah.
Well, I know you said that you loved, the whole consulting. To me, you have to gain a level of respect, and players and teams have to know that you know what you're doing. Mm-hmm. But are there some challenges that comes with that position that you didn't foresee when you first were elected to be a consultant for some of these teams?
Sure. Yeah. Good question. That's a really good question. Yeah, absolutely. I think, like you kind of brought up, being female is a little bit challenging at times. Now, not so much, but I think sort of 10, 15 years ago, maybe a little bit more challenging. It's been really great to see the growth of women in the league, like Dawn Scott, head of performance at Miami, total rock star, right? Like, I love that. She's a friend too. I'm a huge fan of her work, at what she's done at the national team, what she's done at the FA, but like her going in and completely revamping a system and having all of these athletes. She'd be a great guest for you, by the way.
I am trying to get her. I don't even know how I can get a contact for her, but if you happen to know a way, you let me know, because believe me, Dawn Scott has been on my list.
I will help you out. But like, for her, I just think that's fascinating too, because she's just a trailblazer. She's the first for MLS. I know there have been others for other leagues, but I just think that's really wonderful. And I think the more that happens, and having people of color and having minorities represented in a way that they need to be, because our sport is so wonderfully diverse. You from a cultural perspective and language, like look at our national teams, particularly the men, like having a lot of people of color represented right now in the starting 11. It's fabulous. And I think that has been a really wonderful thing. And I think having women come in, I don't want people to think that is necessarily a non-starter, if you will, because I think there's been wonderful evolution. So many women working in the league now at different capacities. And you see that in the NFL and the NBA. And I just think it's a wonderful momentum. However, I've always said this, I never wanted to be the person to check a box, because I didn't want to, I didn't want to feel like, we need a woman, we need this, we need that. And I think,
agree with you.
So it's an interesting dance of like, yes, having representation, but not doing it at the cost of where I'm not going to be respected as others because of my gender or race or culture or anything like that. And people may feel differently. That's just my own sort of, because I'm so driven. And
I was just going to say, it's the drivenness in you, because you mentioned something very interesting. And I was telling someone, like, I don't want to be picked because I played professional soccer or because I'm this. I want to be picked because I became a therapist. I became a journalist. I've worked for that. Right. And even as a journalist, I don't want to be picked, just because you're a physical therapist too. Like, I want them to pick me because they say, she's a great storyteller, or she's a great interviewer, so I am with you on that. I like to work for the things that I'm given, which is great.
Well, you're very good at what you do.
Well, thanks. Well, I want to talk about Velocity Physical Therapy, because you are the owner since 2011. Are you a one-woman show for this?
I have a colleague that works with me. We're looking to hire if anyone's interested.
Santa Monica, right?
Yes.
Okay.
It's not a bad sell. But we're very boutique-y, if you will, and not in a way, not from like an expense standpoint, but just in terms of like, it's one person an hour. We really try to like get granular, get to the etiology quick so that we're really making headway quickly. And I think for me personally, I really like that model because other models, and I was this person, this young, like 20-something-year-old aide, where I was doing most of the interventions with patients. The PT would do the treatment and then pass them on to me. And I didn't have the knowledge base necessarily to like make these nuanced biomechanical corrections. And everything is the assessment, right? The whole treatment is the assessment. So if we're 45 minutes in, I'm like, oh no, let's watch this. What's happening at the subtalar joint, like what, and that I think facilitates better outcomes.
Yeah. And I want to get your honest opinion because I've loved every job that I've worked at, but I know that I have made a cautious effort to find companies where it's just me. I'm doing the whole thing. I'm doing the assessment. I'm doing the treatment. Do you think that it's important for especially early clinicians to have that ability to be able to assess and to be able to also observe the exercises? Or do you think that, it balances itself out, whether they have a tech to do the exercises and they do the actual assessment itself?
It's a great question. I actually was in this situation where I had hired somebody and I had made the recommendation, like I wouldn't necessarily bring a new grad into my particular environment on the sole reason of volume, right? Because we're not seeing enough people a week. So I think there's something to be said about maybe spending 2 years where you're seeing more volume and maybe some more case differential, seeing some neuro, because I always joke, I said, neurology is the new orthopedics, right? Like every orthopedic injury is neurologically based in a lot of ways. I think there's some real upside to like having those experiences. And if you get it in residency or you get it during your curriculum during your clinicals, great. But I do think there's probably some real upside for doing that for a year or two. And then if you're really interested in getting a little bit more nuanced and, where your patient population is perhaps smaller, you're spending more intense time. But I think that might be a great opportunity to do a fellowship or study for your OCS or SCS, something like that. But that's a wonderful question. And I think if I, as a new grad came out, went right into my model, I would have, I think that would not have been the right decision for me, because I think the exposure to the things I saw earlier on in my career helped shape the clinician I am today.
And when you were first starting out, like the outpatient setting that you worked in, was it where you had techs, where you had other people to delegate the exercise, or were you able to go through it all on your own?
Yeah, no, I was in a more traditional model, like an insurance-based model, and I saw pending. I think we had about 45 minutes for an eval, but we had 2 to 3 patients an hour, and I worked with techs. In fact, I just had dinner with my first tech on last Monday, which was so wonderful.
Awesome.
But and again, upside, because I think that was an opportunity for me to help like shape their careers if they're interested in going into like sports medicine or pursuing becoming a PA or PT or PTA. So there's the mentorship aspect of it, which I think I lose out on, with my particular model. But I think from a patient benefit perspective, there's tremendous upside to like kind of being with us through the continuum of the intervention plus the, actual execution of the exercises, just because it's that constant assess, reassess, and pivot, right? Okay, this isn't working, we do this, or we're not getting enough activation here, we do this. And I think if you have that sort of prescribed ahead of time, there's no opportunity, because the tech just really doesn't have the knowledge base to make that, determination. So, yeah.
Well, Holly, you presented, and everyone's going to be surprised because we're not going to be talking about ACL, even though this is like your wheelhouse. You've done so much work, which I for sure definitely appreciate it. But at the Isokinetic conference, you talked about patella tendinopathy. So we're going to just talk a little bit about this. And for my listeners, if you really want to hear about some of her ACL stuff, definitely check out all her research. It's on her website. There you have it. So, with patella tendinopathy, we know that in the knee, there are many generating, sources, whether that's the bursa, the fat pad, the patellofemoral joint. What are the tests that helps you pinpoint that it's likely the tendon that's the source of the patient's symptoms?
That's a great question. So when we look at provocation and whether it's resisted extension from like an isokinetic perspective, that's probably the one. I just had a youth goalkeeper, like a U14 on Thursday, and she was super provocative doing like a straight leg raise after some pretty grueling, one would argue, overloading over the course of the week preparing for surf cup. So I think obviously palpation, I always find that inferior lateral aspect of that tendon to be a hot spot for people who are presenting symptomatically. So I always sort of palpate in that area, looking at patellar mobility, looking to see if there's any obliquity with the hip, and that it is that symptomatic knee, is that hip sitting anteriorly, because oftentimes that will give us some clues on the length tension relationship of the hip flexors and quad. And if that's the case, I always call that the sort of David and Goliath fight, where you've got, you know, two and a half feet of muscle fighting this poor little small tendon. So we want to oftentimes mitigate that. And you know, early on, if you're having a lot of difficulty with engaging the quad, I often will start back chain or work in frontal plane, just get people moving, right? So if you can get them to safely and rather asymptomatically engage their glutes, hamstrings, and lateral hip, and oftentimes we get sort of the endorphin response, and you'll get a little bit of that good sort of pain mitigation response. Find things that they can do, again, because it's about empowering the patient, right? It's not what you can't do, it's what you can do. And that's how we create that workaround. But the patellar tendon's tricky. It is tricky. And it can present itself in a variety of ways. It's been fun sort of doing more of a deep dive, getting out of ligament and going into tendon. But I would say, like, obviously assess the hip, look at the foot and ankle, make sure there's no lack of hypomobility issues there. But then from an absolute tendon perspective, make sure patella mobility is in place, and that, you know, if there's anything we can do from a topical perspective or a pharmacological side, just to help offset, get them into the next phase of, you know, granulation, get them out of that chronic inflammatory phase perspective, that might be a great idea. And yeah, and depending on who's coming in, whether it could be someone, you know, a weekend warrior trying to run a 5K that they haven't run in a long time. So making sure we're looking at strength. Is it a lack? Is there a strength issue? We look at the strength differentials between agonistic and antagonistic groups. So we can look at quad hamstring, quad glute. And if you're seeing big differentials there, make the intervention. I look at the frontal plane a ton, because that can oftentimes play some role. They could be loading the patella tendon because of lateral hip weakness. You know, there's just excessive load because we're underutilizing the frontal plane. And again, that's a great opportunity to intervene. It's typically pain-free working in frontal plane. And that's a win-win.
And when we talk about doing activities that they can do, I think it's also just important for clinicians to understand, like, a patient's irritability level. What are some questions maybe that a clinician can ask their athlete or even just a weekend warrior to get an idea of their irritability level and how they can really progress them and not cause more harm than good?
Sure, great question. So, you know, just, you know, people sort of give the VAS score a hard time, or that whole 0 to 10, but that's their 0 to 10. So it's appropriate, right? And it's pertinent. So oftentimes we can ask them just with like ADLs, are you in a sedan or an SUV? Is it difficult to get out of a low seat? Can you get down your stairwell? You know, is descending stairs a difficult option? So we'll talk about the basics, because oftentimes that's the case. Like this young goalkeeper, that I saw the other day. I saw her prior to going to a goalkeeping training session. She couldn't do an isometric quad set for me without pain. I said, well, we might want to rethink this training session you're about to go to.
Yeah.
You know, so I think it you know, we try to make it as specific to that person. Do they live, you know, do they have a multi-story home or a multi-story apartment complex to navigate with no elevator? Those questions are specific to their particular situation, or what sport or activity, or is it just as simple as like, I need to function throughout the day and I'm really having a difficult time, you know, just getting in and out of my office and like getting out of, you know, a chair.
And when you consider irritability level, is it high irritability? Is it 6 and above? Yeah. Okay.
Yeah. So again, like nebulous and subjective, right? So because oftentimes You might ask somebody that question, and they may report with a 6 or 7, and they are able to jog. Your 2 might be my 5, and so we have to just be careful with making definitive, objective decisions based on like what is subjective reporting. So I think it's appropriate, for the patient. And there again, getting back to what we were talking about a few minutes ago, is like the relationship. This person, are they more of a higher reporter? I often chuckle when I have a patient like, I have a high pain tolerance. Okay, where are we now? A 9. Okay.
I'm like, do I need to take you to the hospital? Okay.
Exactly. But then that's their 9. Okay. That's their reality is their 9. And that's okay. I'm like, okay, let's put you down to a 7. Like, that's our goal for today. Let's try to see if we can mitigate some of that pain and dysfunction for you. So I think that, it's very individualized is basically.
Yeah. Now, if someone is presenting already to the clinic with high irritability, what is your exercise prescription like? Do you just kind of maybe just get to the simple, just isometrics, nothing too strenuous? How do you progress them?
Great question. It depends, so can we get them doing some cyclical loading on a bike, or, do they have a Peloton at home? Can we use some tools? Like, that's the other interesting thing. What do they have at home? What's going to be easy from a compliance and adherence perspective, like for what we're prescribing as clinicians, and what can actually get done at home? It might be super basic. We could do some basic BFR with just, straight leg raise unweighted. Mm-hmm. It's all about the analgesics in the beginning, right? It's just addressing pain, because with pain, if we can get pain down, then we can stop that cycle of the neurogenic inhibition, which then, obviously we can get some quad or, whatever muscle group we're talking about, we can have some resultant atrophy from disuse, or just the decreased cortical efferent output. From a motor perspective, we really need to make sure that we're really mitigating pain, because pain, although it's a wonderful marker and we respect it, but from a functional perspective, if it's left unchecked or untreated, it could be really difficult for them functionally, from a strength perspective, and then overall function.
Yeah. And once we end up mitigating the pain, maybe just during their ADLs, sometimes I'll have athletes who will be a little confused, and you have to educate them again how a tendon works. Say they'll be able to participate in their sport. They have no pain, and they say, later that night I had pain. How do you educate each athlete regarding to this? Because oftentimes I think athletes, they don't understand how tendon really works and how the body responds to load.
I almost have this conversation daily, and I think be ahead of it, so when you're counseling your patient and on the eval, talk to them about how the healing response is. Talk about adaptation curves, like the difference between muscle and tendon and bone and nerve, how they all are kind of in different places on the adaptation curve. But also, one of my favorite sort of metaphorical stories to tell is like, this is a bit of a roller coaster. We are going to get to the top together. We will, but there are some little bumps in the road. You're going to kind of have your downs and your ups, but the steady slope is up, and we will get to where you and I want you to be. And we will do it collectively together. And sometimes it takes a little bit longer than your neighbor had their experience with, or your teammate, because everybody's a bit unique from a biochemistry perspective. But I think that's really an important conversation, because intellectually, then they're prepared for, oh, I'm a little sore. And that's not a bad thing, right? That's adaptation of the tendon. And that is tendon remodeling. And that's what we need to happen. But if that conversation is done prior to them actually getting sore, completely different interpretation of that for them, right? So I would say that would be one of my best pieces of advice clinically. Give them potential case scenarios ahead so that they intellectualize it. The best, I think one of the most valuable things we do as PTs is patient education, be empowering the individual, right? They don't want to rely on us. They shouldn't rely on us for a long period of time. We're a source of resource for them, a source of guidance. We prescribe, but then the idea is to get them, independent and autonomous in a way that they're then ahead, like they know, oh, this, I remember Holly told me this a year ago, and I can intervene on my own,
Yeah.
So
And I
think
think
that's
that
really
even
important.
goes with even like just actually loading the, because some people, and I know
Mhm.
when I was an athlete, I think I
Mhm.
became a physical therapist because I had so many injuries and I was
Mhm.
frustrated and I never knew
Mhm.
why I had pain. But even just understanding that you might have some discomfort when you're exercising with, whether it's an Achilles tendon issue,
Mhm.
because the tendon does need a remodel. So I agree with you. I think there are things I wish I knew as an athlete that could have set
Mm.
me up to be, maybe I could still be playing. No, I'm just kidding. I'm retired for good, which I'm happy about.
The
Well,
over 30, over 40 leagues. Woohoo.
do you play now? I'm very
I
curious. I
still,
might
well,
join your team.
yes, well, I was playing up until I had my son. And then I was just telling
Wow.
my husband, I'd love to get back. Well, it's wonderful. And that's another awesome part about our sport. Again, huge bias, but we can play,
Uh-huh.
we'll get later in life and it's really fun. We have a lot of adult leagues in SoCal. So absolutely, next time you're out.
Yeah,
Uh,
I know. You know what's interesting is after I finished journalism school, I was like, you know what? I'm gonna like try to find a soccer league, and life has still been so busy. But then when I
right.
look at people like you, I'm like, she's married, she has kids, she's doing all this stuff. Like I should be able to make time to play soccer, you know? Well, Holly, I know
Yeah.
that the final thing is okay, an athlete needs to get back to their
Mhm.
actual
Mhm.
activity. What are
Mhm.
some milestones or things that you consider before you clear an athlete? And,
Mhm.
not necessarily clear an athlete, because I'm
Mhm.
assuming they're still playing. They're not going to just be out of their sport,
Sure.
but at least you kind of let the reins loose and let them continue on their own.
Sure. Great question. So one of the things I do a pretty robust strength assessment, and this could be done doesn't entail isokinetic testing. So if you get a really good handheld dynamometer and get a good setup, particularly for leg extension, I find that handheld. I fixed mine because I just can't provide enough resistance for some of the athletes we would be seeing. From
Uh-huh.
so if you have fixed points where you can actually fix the device, so you're really getting a more accurate representation. But we'll look at quad, hamstring, hip extension, external rotation, abduction, adduction, plantar and dorsiflexion, hip flexion as well. And then I'll map that out over a course. So I have an Excel sheet, we follow it out, and we might test that at multiple points because we're looking, it's fluid, right? So what one muscle group presented a couple weeks ago, where let's shift our goals a little bit. And then maybe an unintended consequence, we lost a little bit of strength there. So we pivot, right? It keeps us
Mhm.
honest, which I
Yeah.
love. Another wonderful tool, which I would encourage everyone to consider getting because they're super cost effective now, is a surface EMG. I personally use M-Trigger. I have no relationship with the company other than I like it. But there are several other models and makes out there. They're about $450, I think. But remember what we said, neurology is the new orthopedics. So if there's a cortical issue there, right? If there is some underlying neurogenic inhibition, particularly with tendon, we see that a ton,
Mhm.
where that could persist, where we need to get the cortex firing appropriately. Efferent, is that afferent loop doing its thing? Is there an issue with the interneuron? And we won't have all of that granular information, but what we will know is that, okay, there is a difference between what's happening on the right and left quad. And then
Mhm.
the assessment then becomes the treatment, particularly for athletes. You're like, okay, here's your EMG. Let's use this during training or during physical therapy, and we'll see. Oh, and they're competitive, right? So, okay, let's get your
Mm.
microvolts to look similar. So I think that's a great tool, a biofeedback. So the EMG is the assessment, and the biofeedback during the actual PT intervention. That's a great thing. And then some of these wonderful tools, like if you have access to them, some of the force decks and like looking at ground reaction forces, if you have that ability in your budget. If you don't, use your iPhone, a calf raising, so you can get wonderful apps out there that will help you measure, looking at heel rise
Oh.
testing.
What app did
That's
you say? What app did
um,
you say? Do you know a couple?
I will get back to you on that. There's My Jump is wonderful,
My
like a
jump.
looking at
Okay.
vertical, and there is one for specific for calf. And looking at calf raising, or just what you could do, like a good little hack is put your measuring tape up, have them do it next to a wall, and just videotape it, and then slow it down. It
Ah,
doesn't need to be super fancy.
that's a
Yeah,
very feasible one that I
yeah.
would probably do in my clinic.
Yeah.
Ah, that's a good
So
one.
super cost effective, and then you're objective, right? And then again, you can show that back to the patient. Are you looking at okay, and this is important because we're looking at rate of force development and power generation, right? And overall strength. So sometimes fascinating, like I have a player come in and from a strength perspective, everything's looking good, but they keep getting these recurrent bouts of either tendinopathy or muscle strain. And they're meeting all of their metrics, and then suddenly the EMG looks very different. And they're like, okay, we've got a more neural underpinning here. So we have to just spend some time on perhaps some underlying neural inhibition that hasn't been addressed appropriately. And it's fascinating. And I would counsel people to say, if you're having difficulty on getting a player back and just like, oh, it's just not adding up, I would say look to the surface EMG if you have that tool available to you, because it's really been illuminating. I'll be honest with you.
Yeah, that's interesting. Because like you mentioned, even during that presentation, is that even though they've had this injury and maybe they've recovered to some extent, sometimes the brain is still preoccupied about this given injury.
It's fascinating. So that when we look at the cortex, I mean, our brain is like the helicopter parent, right? What it's trying to do is prevent you from re-injuring yourself, because it will shut down motor efferent output. It will, in order to protect you. Like, don't do that. We're looking to offset this whole pain response, and then the afferent feedback either becomes amplified or not. And then what's really fascinating is what's happening in that conversion. So remember, if we shake off our neuro cobwebs, coming into the afferent, and remember that relationship into the dorsal root ganglia, and when you're getting that interneuron conversion. And I think they're like the translators, right? This is what happened. I always tell my patients, okay, your joints are like GPS units. They're giving information back to the brain, right? And then the brain interprets that. That's the interneuron sort of conversion translator. And it's a game of telephone. And sometimes those messages, what the interneuron may perceive as incoming information from the tendon may be like, oh, that's really mild, where it should be, no, this is really a bit of an issue. So it should mitigate efferent output, or the reverse, right? You have that information coming in and it's mild and it's being hyper amplified by the interneuron. And then you're like, oh, efferent out. And then we get the sort of mild disuse atrophy. And then we get this perpetual cycle, because now we have a pain, a weakness driven pain syndrome versus just an inflammatory state.
Yeah.
So
finally, because you've given so much advice for medical providers, there are actually some athletes that tune into some of these episodes, which I'm quite impressed. Yeah, they're soccer players. What advice could you give to an athlete who may be one of the frustrated athletes that seem to constantly be getting this type of injury?
Really talk to your clinician or your PT, your ATC, whoever you might be working with, in terms of, I'm frustrated because of X, and I want to be able to, my goal is to get back to play for this particular tournament, this particular game, this part of the season, to play recreationally. And I think if you're not getting the sort of the answers, or you're not making the gains, be a little introspective and to make sure, and this is rarely the case, most of my patients, I have to pull reins back as opposed to encourage to do more, but make sure you're really being honest with yourself. Are you doing more that's prescribed? Is that perpetuating the overload? Or are you doing too little? Are we underloading? So make sure you're just kind of internally checking to make sure, like, what has been prescribed to you and what your physical therapist is interpreting is what you're loading, is what actually is being done. So there's that. Keep a log of, like, so that way we can get pretty granular and work back with you. Okay, let's see your log. What did you do? What were your symptoms like? Did you ice? Did we do BFR? Did you have a Normatec available to you? Did we have any of those tools? If not, that's perfectly okay. But that way we can kind of like work back. Again, it's we're detectives, aren't we? We're like trying to see and really map out. And the one other visual, in addition to kind of talking about that whole roller coaster analogy we were speaking about earlier, show them a dose response curve. And like, our whole goal is to keep you under this line, right? And you're going to have very high performance capabilities without jumping over into that sort of inflammatory state. And it's interesting for women too, because that can shift certainly with age, or differences during their menstrual cycle when estrogen is surging or not. We have a ton of receptors on our tendons and ligaments for estrogen and progesterone. So there could be some cyclical element to that. And there again, Dawn Scott and Georgie Brunes out of Brussels is doing tremendous work in that regard. And I think those are good conversations for us to have with our female athletes, because that can be playing a role too. Are they on birth control or not? And with birth control, usually we have a little bit of a dampened response. So that's usually a little bit more in check for those that aren't. So again, these are all conversations, because we have to think, okay, if we ruled out strength, neuro, we kind of have to expand our cap. Obviously it's outside our scope of practice, but we have the conversation like, hey, is there perhaps some adrenal pituitary element here? We have to think of REDS and female athlete triad and things like that as well.
Yeah, that's really good. That's really good, because no athlete likes to do the same rehab for 3 to 6 months and not see any type of results.
Not any change. And that's on the PT side. I would say the advice to myself would be, well, then we need a new set of eyes, because maybe I'm not seeing what I need to see. And that's to all the athletes out there. We want to empower you. There is no shame in switching clinicians, because if it's not the right fit or we're not seeing what we need to see, please go get second and third opinions, because it's everyone's goal. It's not an ego thing. Everyone's goal is to get you back to where you want to be the best version of yourself.
I like that. That's good. Yeah. Well, Holly, I have to say that you are definitely one of my biggest role models in the sports medicine world. And I'll probably be picking your brain for quite some time, especially now that I will be entering the journalism world, and I'll have to be cross-checking all my facts with someone that's much more smarter and with much more experience than me. But we are so appreciative. I know the sports medicine population is so appreciative of all the work that you've done. And I know that I'm going to still see you in all these future conferences, because you just pop up everywhere, not with your family, just you, but you're always there. So
I do drag them along. Funny thing, my husband's joke is, they were there in Lyon. My husband jokes my 6-year-old has more frequent flyer muscle miles than he did when he was 35. And I would love to talk to you about that, because that's a whole nother little podcast of being like a female working mom researcher, and how conferences may be able to help moms or women that are looking to start families, so we don't have to drop off the radar, and how we can facilitate maybe having an paid au pair service, maybe, all sorts of interesting things. That might be a topic we will talk about in the near future. Yes. Yeah. So it's an interesting thing. And to again, encourage people like, hey, we're going to make it easy for you to attend, or easy for you to be involved, as opposed to, well, I can't come for 15 years because I have kids, I have families.
I agree. I have no kids, no family yet. So I feel like I'm unattached. I can just go wherever it seems necessary. So
exploit that. And please, very flattering.
Thank you so much for your time. I know we'll see each other in the near future. Maybe you'll start to see me eventually covering a soccer league that you're working in, and you'd be like, hey, I remember her. And please don't ignore me when I wave at you, okay?
Never. Such a pleasure. Thank you so much.
Pleasure speaking with you. Thanks so much.
Likewise. Bye. Okay. Take care. Bye.
Thanks for tuning in to the episode with Dr. Holly Silvers-Granelli. Make sure that you rate, download, and share with your friends. We'll check you later.